All right, welcome everybody to this session on the microbiome and medicine. This is presented through the Science and Innovation Center. So we're glad to be able to connect with you, although we can't be in person this year. My name is Ben Kopp. I'm from Nationwide Children's in Ohio State. And I'm pleased to be moderating a panel session today with three talented physician scientists. This session will be recorded, so please take note of that. Our three panelists are going to give their presentations in a row, and then we'll follow that up with question and answers for the individuals in the group at the end. So please type your questions into the chat, and I will take care of those at the end. Thank you all for your attention ahead of time. So we're going to have three kind of unique but overlapping sessions that discuss how we can use innovative technologies regarding the microbiome and integrate it into our clinical practice and aspects of that affect various both acute and chronic lung diseases. So all three of our panelists are from the University of Michigan. First one is going to be Lindsay Caverly, who's an assistant professor of pediatrics. She's going to be discussing the role of the microbiome in cystic fibrosis. She'll be followed by Yvonne Wong, who's an associate professor of pulmonary critical care medicine, who's discussing the microbiome in asthma and COPD. And then finally, Bob Dixon, who's also an associate professor, discussing the role of the microbiome in critical care medicine and bringing that to the bedside. So really excited for this session. Thank our speakers for their presentations today and really giving us some innovative technology and how we can continue to move our science forward. And I also want to remind the audience that there are many other sessions in this Science and Innovation Center. There are live sessions each day, as well as the awards reception and the PhD in translational science research reception. So please check those out in addition to all the rest of the ATS content.
Okay, well, thank you, Ben, for the introduction, and thanks for the invitation to speak today. I'm sorry that we can't be here together in person, but I'm looking forward to speaking with you virtually about the multidisciplinary management of complicated cystic fibrosis infections. So a brief overview. First, I'll give a little bit of an overview of cystic fibrosis airway infections, including the epidemiology, pathophysiology, why we're interested in CF airway infections in this forum today. I'll review the multidisciplinary clinic for complicated CF infections that we've started here in pediatrics at the University of Michigan, working with pediatric pulmonology and infectious diseases. And I'll give a couple case examples of some of the complicated CF infection patients that we've seen in this clinic and how we've been able to apply some of what we've learned from culture-independent studies of the CF airway microbiome to our approaches to some of these difficult patients. And I'll include insights into CF exacerbations and some considerations for CFTR modulators, as these have really changed the landscape of CF airway infections and are going to continue to do so going forward. So I'll start with acknowledging that we've known that CF airway infections are important to the pathophysiology of CF lung disease since the very first description of cystic fibrosis in 1938. Dorothy Anderson published the first description of CF. And in this description, she described a number of infants between ages 1 month and up to about 3 years of age. And it was autopsy reports of these children. She described it as cystic fibrosis of the pancreas. But of note, in virtually all of these kids, there were bacteria found in the lungs on autopsy. The most prevalent of these bacteria was Staph aureus, as you can see here, and really emphasize that airway infection is a part of the CF phenotype since the very beginning. And over the next number of decades, recognition of the increasing importance of infection, the development of antibiotics, and aggressively treating CF infections has really played a critical role in improving the mortality from people with cystic fibrosis, estimates which have continued to improve until today. But they're really around the time of the advent of antibiotics and their application to CF, there was an initial doubling of the expected lifespan for people with CF between the 1950s up into the 1980s. And this has continued. To take a look at the epidemiology of CF infections, the prevalence rates of what are considered the known CF pathogens, Staph aureus, Pseudomonas aeruginosa, methicillin-resistant Staph aureus, and then some of the gram-negative bacteria, including Stenotrophomonas, Achromobacter, and Burkholderia related organisms. This has changed over time, and this is related again to changes in outcomes of CF infections. So These are data from the cystic fibrosis patient registry in the United States and look at the percentage of individuals who have cultured positive for these CF pathogens over time. And you can see that over the past 20 years or so, prevalence rates of Staph aureus have increased. Prevalence rates of Pseudomonas over the same time frame have decreased. And there's been concomitant increases, as I said, in Staph aureus prevalence rates. Non-tuberculous mycobacteria isn't shown here because it has not been tracked for as long in the CF patient registry, but prevalence rates of this has increased over the past couple of decades too, with recent estimates being about 20% of people with CF are culture positive for non-tuberculous mycobacteria. So changes in the prevalence rates of the CF pathogens has correlated with improvements in survival over time. And of note, these prevalence rates have changed over time along with improvements in outcomes independent of CFTR modulators. So this has been in progress even before CFTR modulators, the first of which was approved in 2012. And the recent era has included direct treatments of CFTR dysfunction from these modulators. And as we'll talk a little bit more later in the talk, this is anticipated to continue to have a big impact on the changes in CF infection epidemiology. So to look at CF airway infections from a slightly different standpoint, the prior data were all culture-based. So clinical cultures taken through routine clinical care, cultured in the laboratory with selective culture approaches that are designed to identify the bacteria that are known CF pathogens, which were listed before. But we have learned from culture-independent studies that the epidemiology of CF airway infections looks a little bit different in ways that do relate to outcomes of CF infections. So this was a study from the group in Colorado and was a multi-center study looking at bronchoalveolar lavage samples or BAL samples from 93 patients, and they looked at the bacterial communities through 16S rRNA gene sequencing. And they broke down the median relative abundance of these bacteria, classified by whether or not they were a traditional CF taxa, so Pseudomonas, Staph, Burkholderia, what we mentioned on the prior slide, versus non-traditional taxa, which were predominantly oral anaerobes. So genera such as Prevotella, Vianella, Rothia, obligate and facultative anaerobes, which are prevalent in CF samples when you look at it with culture-independent techniques, as well as culture-based techniques when you're specifically looking for the anaerobes. But you can see from these data, the relative abundance of these groupings of bacteria does change with age. So in younger kids, the non-traditional taxa are more abundant. This declines with time. Conversely, the relative abundance of the traditional CF taxa, so Pseudomonas staph, increases over time. And these changes parallel the decline in lung function that we know happens with age too. So again, from the CF patient registry, this was looking at FEV1% predicted with age. And even across different cohorts based on year, we've had improvements in the overall predicted survival and overall lung function for a given age over time. But the trajectory really has been the same over these decades, where lung function is high in early childhood and then starts to decline through the teenage years until early adulthood. So with advancing age and decreasing lung function, we have this pattern of increasing relative abundance of CF pathogens, decreasing relative abundance of non-traditional taxa, which again are predominantly oral or obligate and facultative anaerobes. This is also represented by a decrease in overall bacterial community diversity. So these are measures which include both the number of taxa and the distribution of these abundances. So that's over the longer term in terms of decline in CF lung function over time in relationship to changes in CF airway microbiota. But this holds true over the shorter term as well. The general pathophysiology of CF airway infections includes a cycle of infection, inflammation, airway mucus obstruction, and perturbations to this cycle result in pulmonary exacerbations, which are short-term increases in signs and symptoms of CF lung disease, often characterized by cough, increased sputum production, increased fatigue, weight loss, and often with a decrease in lung function at the same time. Antibiotics are the cornerstone of treatment of CF pulmonary exacerbations, and airway clearance is also an important part as well. And this treatment approach results in short-term recovery and lung function symptoms in the majority of patients. However, there is a significant minority where the typical approach to pulmonary exacerbation treatment with antibiotics, which are typically directed at the predominant CF pathogens recovered from the airway cultures, there is a percentage of patients, maybe about 20%, who do not recover in the short term from exacerbations with this treatment approach. And then also over the long term, even if you have short-term recovery, repeated pulmonary exacerbations over time are associated with an increased rate of lung function decline over time. So there's definitely room for improvement in how we manage pulmonary exacerbations. And some of the knowledge gaps that we hope that culture-independent studies and new approaches to studying the CF microbiome can address include: how do we better understand the pathophysiology of CF infections, both over the short and the long term? And how can we better manage CF infections? How can we use these data to then apply this to better treatment approaches, including antibiotic treatment? How can we better predict and prevent either exacerbations or accelerated lung function decline over time? And ultimately, how can we use this information to improve outcomes in people with CF? So to help address some of these issues, we formed a multidisciplinary clinic for complicated CF infections at the University of Michigan. And as I said before, this is a collaboration with the pediatric pulmonary department, and I've been the person involved with this, as well as our pediatric infectious disease group here at the University of Michigan. So we have a joint clinic where we see referrals for patients with cystic fibrosis and complicated infections from our center and then other centers regionally at the University of Michigan Children's Hospital. And we see them, they're also seen by RTs, and we can pull in other members of the CF team as needed. So pharmacists are typically involved, and our trainees are as well. And then if dietitian or social workers are relevant to that particular visit, they can join in as well. So we offer evaluation and treatment recommendations for these are the infections that typically are referred to us. So non-tuberculous mycobacteria is what we've seen most often, but we've also received referrals for Burkholderia infection, fungal infections, including Aspergillus, multi-drug resistant Achromobacter, MRSA, and really any difficult to treat bacteria and fungal infections in CF. And we have the sort of requisite, slightly embarrassing picture of myself and Dr. John LaPuma, who's the ID physician who participates in this clinic with me that we use for our marketing. So I'll move now into a case or two that we've seen in this clinic and give just a brief overview of the case, as well as how we've thought about these cases in the context of the data on CF airway infections, mostly from culture-independent studies in recent years. So the first case is a 20-year-old man with cystic fibrosis. He comes to us with the primary question of, he said, recurrent exacerbations, please help us assist in antibiotic selection for the next time he gets admitted to the hospital. And this is a pretty common scenario that we've seen. For this particular patient, his baseline lung function was about 50% predicted. And he's admitted to the hospital 3 or 4 times per year with pulmonary exacerbation. His sputum cultures tend to be positive for Achromobacter, Xylus oxidans, and is multi-drug resistant with kind of variable resistance patterns over time on repeat culture. And the team that referred him was wondering, how can we help optimize his antibiotic regimen and plan for treatments for his next exacerbation. So in thinking about this, first I'll touch on some of the insights that we've gained into CF exacerbations over the past number of years from culture-independent studies, particularly in terms of what we've learned doesn't change with CF exacerbations. I mentioned before the triad of airway infection, inflammation, and mucus obstruction that, when perturbed, leads to CF exacerbations. But the conventional wisdom on CF exacerbations within that framework has been that exacerbations are related primarily to increases in the total airway bacteria and or the CF pathogen abundance. And this is how I initially learned about CF exacerbations, that it's a blooming of the Pseudomonas or a blooming of the total airway bacteria. And we've learned in recent years that this isn't necessarily the case. And neither the total bacterial load nor the CF pathogen relative abundance consistently increases when patients go from their baseline state to their exacerbated state. And this is just one example. This has been shown in multiple studies, and I referenced George O'Toole's review article from Journal of Bacteriology down here, which has a nice review of what we've learned about CF exacerbations. And this is one piece of data from the study from the LaPuma lab back in 2013 that looked at 28 patients with paired sputum samples collected pre-exacerbation at their baseline clinical state and at exacerbation. And this was looking at the total bacterial load with total 16S copies. And you can see that there was not an overall increase in total bacterial load when patients moved on to an exacerbation. And again, this is also true in total abundance of CF pathogens. So in addition to exacerbations not being clearly caused by changes in total bacteria or changes in the total abundance of the CF pathogen, one of the next question was, well, what does change? Is there something else that's consistently changing and potentially causing exacerbations in people with CF? The overall message here has been that there is no one common exacerbation signature across the population. There's no one other identifiable bacteria or identifiable community structure change that applies across the population to people with CF. And this is just one example of these data. So this was from the group in Toronto, and it looked at 296 patients in sputum samples, and both pediatric and adult patients. This particular figure here was looking at the Shannon diversity amongst these sputum samples, again, using 16S rRNA gene sequencing, looking across people at their baseline clinical state, at time of exacerbation, on antibiotic treatment, and then in the recovery phase following antibiotic treatment for the exacerbation. And you can see that there's no significant change in bacterial community diversity in either pediatric or adult patients that coincides with the transition from your baseline to your exacerbation state. And similarly, when they looked at the global bacterial communities based on their clinical state, in this ordination plot here, there's no clear clustering of exacerbation samples together. So here the axes are colored by the predominant taxa in the sputum samples, so Streptococcus, Haemophilus, Pseudomonas, etc. The closed squares are the baseline samples, and the open squares are the exacerbation samples. And you can see just grossly that the exacerbation samples are not clustered together. So again, there's no one clear exacerbation signal that's driving this across the population. But when you look more deeply into some subsets of exacerbations, there are some patterns that come up when you do some relevant groupings of people with CF. This was another study from the Lupuma lab here in Michigan. It looked at 631 sputum samples from 111 people with CF, again with 16S rRNA gene sequencing. And similar to the prior slide, it looked at the relative abundance of the different taxa and community characteristics between people at their baseline or B, exacerbation E, on antibiotic treatment T, or in the recovery phase R following exacerbation treatment. Except in this one, instead of looking across the population, in this study, the population was subset based on lung disease stage. So people with early lung disease stage had an FEV1 greater than 70% predicted. And you can see, looking at it this way, this is looking at the relative abundance of anaerobes grouped together. So again, those oral anaerobes that I mentioned before, genera such as Prevotella, Streptococcus, Fionella, Rothia, are grouped together. And there was a significant increase in the relative abundance of the total anaerobe grouping coincident with exacerbation in people with early stage lung disease. The same pattern was seen in people with intermediate stage lung disease, so an FEV1 between 40% and 70% predicted. You see the same sort of overall increase in the relative abundance of anaerobes coincident with exacerbation. But finally, when you looked at people with advanced lung disease, so an FEV1 less than 40%, this pattern did not hold true. So no change in the relative abundance of anaerobes between baseline and exacerbation in people with the most advanced lung disease. And this perhaps makes sense that people with advanced lung disease, as we discussed before, tend to have very low diversity bacterial communities that are dominated by the CF pathogen. So in the graph before of the CF pathogen relative abundance increasing over time. So things like this suggested that there may be some consistent changes with exacerbation that we can learn about. However, these don't necessarily apply across the entire population and may be specific to certain subsets of the population, such as with different lung disease stage. A more recent study looked at within-person changes in the metabolome and microbiome. So shifting now away from just characterizing the bacterial community structure to looking at the metabolic activities of the bacteria. And this looked at just 6 patients, but very, very granular sputum samples, 594 sputum samples over the course of 1 year of these patients. And in this study, in the metabolome, one of the interesting findings was that when you look within patient of the Bray-Curtis distance over time leading up to exacerbation. Here we have ST as the stable state or baseline prior to exacerbation, and then again on antibiotic treatment. There was a significant decrease in the Bray-Curtis distance at exacerbation. So again, this is the within-person change became less at the time of exacerbation in the metabolome. So less variability in the metabolome was associated with exacerbation. Looking at the microbiome, they found that within patients, there was an increase in the ratio of anaerobes to CF pathogens preceding exacerbation. So consistent with the prior slide that I showed, the findings that overall the ratio of anaerobes to CF pathogens here in the blue is increasing over time leading up to the antibiotic treatment phase, the AB in the center, And then on antibiotic treatment, that ratio again decreased. So a decreasing ratio of anaerobes to CF pathogens preceding exacerbation. So data such as these suggest that there could be a potential role for anaerobes in CF exacerbations. But what would be the potential mechanisms that would be relevant here? Well, there have been studies that oral anaerobes in CF can be inflammatory. They are metabolically active. Short-chain fatty acids have been linked to inflammation in the CF lungs. There's also data to suggest that the anaerobes are working in conjunction along with the CF pathogens to potentially be increasing the pathogenicity of them. And this is one of those. This is one of the studies. This is from the Hunter Lab at the University of Minnesota. And this looked at a co-culture model of CF pathogens and oral anaerobes. So here we have Pseudomonas with agar in culture on the top here. And then the plus and minus is with and without oral anaerobes with mucin. And so in the negative tube, without the oral anaerobes, Pseudomonas was not very efficient at utilizing the mucin as a carbon source. However, with the oral anaerobes added to the culture, the anaerobes were able to ferment the mucins and provide a carbon source for Pseudomonas and really robustly enhance the growth of Pseudomonas in these culture tubes. So this held true both with Pseudomonas and also with other CF pathogens that they investigated. So Chromobacter phylosoxidans shown here, Burkholderia sinusopatia, Staph aureus, and Stenotrophomonas in the co-culture tubes with and without anaerobes, again, plus with anaerobes and negative without anaerobes. The mucin degradation by these oral anaerobes was able to facilitate the growth of CF pathogen. So suggesting another method by which anaerobes could potentially be contributing to the pathophysiology of CF infection and CF exacerbation, potentially. The other way in which we've learned about CF exacerbations from some of these culture-independent studies has been in explaining the antibiotic resistance variation in CF. In cystic fibrosis, the relationship between antibiotic susceptibility testing and response to therapy differs from other infectious diseases. So the link between those two is poor. So using the results of the antibiotic susceptibility testing to direct CF therapy is not as clearly linked to improvements in outcomes of exacerbation as would be expected with, say, UTIs or pneumonias in the general population. And this is multifactorial, but one potential explanation for this was found in this study of within patient differences in about 12,000 Pseudomonas aeruginosa isolates across the lung regions in 10 lung explants. So they took these lung explants, they dissected out the Pseudomonas colonies, and they performed whole genome sequencing and proteomics on the Pseudomonas isolates. And they found that in the proteomics, the lung regions differed in the Pseudomonas proteome. The strains were the same. So within a patient across the different lung regions, it was a single Pseudomonas strain was infecting the lungs. However, you can see here that the proteome in this ordination, it does cluster strongly by lung region. So regional heterogeneity in the proteome of the Pseudomonas isolates was found in these lung explants. And similarly, when then they took the isolates from the different lung regions and did antibiotic susceptibility testing on these isolates, this differed by lung region also. So here we have this is an example from just one patient. We have antibiotic susceptibility testing on 3 different drugs, tobramycin, ciprofloxacin, and ceftazidime across the different lung regions. And you can see that this varies across the lung region. So emphasizing that the antibiotic susceptibility results that you get with a single sputum sample is really just one snapshot in time and probably just represents one particular region of the lung, whichever one happened to be where that particular sputum sample was from. And so with this information, we think about antibiotic susceptibility as really being one snapshot in time. So when we're thinking about the patient that I presented earlier, we would think about the most recent susceptibility results as being more a piece of the puzzle rather than dictating the current treatment. So we would look at that antibiotic susceptibility pattern, but we also tend to look back over time, over the number of antibiotic susceptibility tests over the past year, sometimes even more than that, and incorporate all of those into our treatment decisions. So if someone had a result that was susceptible versus resistant at the time of admission versus in the prior year, we'd really look at those sort of comprehensively as each of those tests being probably representative of the different regions. We try to think about the antibiotic susceptibility of the lungs and the community as a whole in determining our antibiotic treatment. We also, in terms of thinking about the prior patient and the difficult to treat exacerbations, I think The question about what do we do about the anaerobes and the data on anaerobes in the CF lung, I think is really less clear. And the standard approach still is to not direct treatment against them, but we do think about in the difficult to treat exacerbations, considering the role of anaerobes in exacerbation treatment. So one final case here. This is the case of someone with new NTM infection and determining the need for antibiotic treatment. This is a 16-year-old girl with CF who had a recent sputum culture newly positive for Mycobacterium abscessus. Baseline lung function is 70% predicted and stable. She's had a mild increase in cough, sputum production, fatigue, has chronic Pseudomonas infection. She's tried Trikafta previously, but stopped it and is considering it again. And so we're really trying to decide how do we incorporate the role of the CFTR modulator in the treatment of NTM infection and in terms of the workup of NTM infection and determining NTM pulmonary disease. As I mentioned before, the treatment of CF infection has focused over time primarily on the effects of CFTR dysfunction. And it's really just been in recent years with the advent of CFTR modulators that we've been able to look at direct treatments of the CFTR dysfunction with these modulators, which help increase both the quantity and the function of CFTR at the cell surface. And the recent introduction of Trikafta in 2019 now makes these modulators available to over 90% of the CF population. So this is anticipated to have a big change in microbial epidemiology in people with CF. To highlight just a little bit of this data, this was one observational study of outcomes 3 years post-ivacaftor approval in the US and the UK CF registries, and people on ivacaftor in the light bars compared to people not on ivacaftor in the dark bars. And there was a significant decrease in the prevalence rates of the majority of CF pathogens in people with ivacaftor. And NTM was one notable outlier in these data. So decreased prevalence rates of both CF pathogens. And this was a combination of decreased acquisition of infection and also clearance of infection, which did happen more often in younger, healthier patients. So if you had new Pseudomonas infection or you were younger with better lung function, you were more likely to clear your Pseudomonas infection. But there's also been data to suggest that even though there may be some impact on infection, these changes are not necessarily sustained over time. So the group in Seattle looked at 12 adults with CF and sputum samples following ivacaftor initiation. After 1 year of ivacaftor, these patients all had clinical improvement in CT scan, sputum inflammatory markers, and sputum bacterial load. However, there was a marked decline in Pseudomonas aeruginosa in terms of the abundance of the bacteria over the first week. This was sustained over the first year, but by the time they were about 30 months out, this really had rebounded to the prior level, suggesting that there may be transient improvement, but things maybe will re-equilibrate to the pre-modulator levels over time. None of these patients cleared their Pseudomonas infection. They were adults with more advanced lung disease. And again, the same Pseudomonas strain maintained infection over the subject over the time. So another question is what measures of the microbiota might be relevant in terms of determining the effect of ivacaftor and the other CFTR modulators on the airway microbiome. One recent study looked at 20 adults with CF over 1 year of lumacaftor ivacaftor treatment. And this looked at subjects before lumacaftor ivacaftor in number 1 here, and then sampling every 3 months over time after starting it. And in this study, the metabolomics of the sputum samples measured with both GC-TOF or HELIC-TOF did not show a significant change in the sputum metabolome over time. However, the exhaled breath condensate sampling did show a shift over time. So again, one is the pre-modulator, and then you can see all of the post-modulator samples are clustering together, suggesting that maybe sampling of the whole bacterial community is a more accurate representation or gives a different picture of how the microbiome may be affected by CFTR modulators. And then lastly, what is the potential impact of CFTR modulators on NTM infection itself? Well, we really don't have very much data on this specifically. Since CFTR modulators are expected to have an impact on the overall community, I'll point to a recent paper from my group on the potential relationship between the overall bacterial community structure and NTM pulmonary disease. And in this study, we looked at 24 patients with CF and new NTM infection, and looked at longitudinal sputum samples from the 2 years prior to the incident NTM infection and the relationship to subsequent diagnosis of whether or not they had NTM pulmonary disease. And with these time series analyses of the bacterial community networks, we found that overall the bacterial communities before NTM infection even happened was associated with whether or not they had a subsequent NTM pulmonary disease diagnosis. So here we have NTM disease on the top, no NTM disease on the bottom. And these community networks were different in terms of the number of nodes that are present, the interactions between the nodes, and the general structures of the community, suggesting that the general structures of the bacterial community could play a role on how the NTM behave once they are infecting. And so with data such as these, still we don't know exactly how this is going to impact NTM or other infections, but we do consider that the CFTR modulators are going to impact bacterial communities, both directly and also indirectly through changing mucus clearance, changing lung function over time, and preventing lung damage. So in conclusion, we talked about our multidisciplinary clinic for complicated CF infections, the collaborations that we've built between pulmonary and infectious disease teams, and how we've used this to translate some of the culture-independent study data into clinical care, insights into CF exacerbations, including potential role of anaerobes in some exacerbations, the bacterial community overall is sort of a pathogenic unit, and how anaerobes and CF pathogens could be working together, and how community structure can be relevant, and how we think about the regional heterogeneity of CF lung disease in terms of thinking about antibiotic resistance. And finally, this will be a really exciting time for CFTR modulators, and these are going to have a clear impact on CF lung disease and infections over time. And this is going to differ between patients with established lung disease versus less established lung disease. But there's really a lot of unknowns and a lot of interesting data that's going to come out of this region together. So thank you for that, and we'll be taking questions at the end of the group.
First of all, thanks to the organizers for the opportunity to speak at this Science and Innovation Center session. I'm going to be speaking to you about cross-disciplinary strategies from my viewpoint and how to dissect host microbiota interactions in clinical translational studies of asthma and COPD. I have no relevant disclosures for this talk. My goal for this talk over the next 20 minutes is encapsulated here, is to really sort of present and talk through a conceptual framework for clinical study design and sort of a rational thinking about how to collect samples and generate data and analyze it, and provide you with a couple examples of evidence and approaches that we and others who are studying asthma and COPD across the lifespan have implemented to give you an idea of approaches that may be applicable to your questions of interest. So in thinking about the potential of host microbiota interactions and their role in chronic airway diseases, which in some ways is more challenging because we're dealing with the end result, so to speak, of possibly a lot of processes that have been in play for a number of years. But the areas that I have started here are sort of the way I think about opportunities that the host and microbiota interactions may interface to shape susceptibility to disease and actually the genesis of disease. And then once disease is established, how these host microbiota interactions may continue to shape the phenotypes and endotypes of disease that we see and potentially impact the responses to treatments. Diving into this a little bit more in terms of asthma as well as COPD, just to expand upon this in asthma, as most of you know, it's a chronic disease that can span the lifespan, beginning potentially in infancy, and even prenatal exposures have been shown to potentially influence susceptibility to asthma. But really, it's a disease that can either remit over time or persist over time, and those factors that are involved in that are not really well understood. As an adult pulmonologist, I spend a lot of time thinking more about sort of the endotypes or phenotypes and potential endotypes of chronic asthma as well as COPD that we see in the clinic. From an immunologic perspective, we do know that atopic sensitization plays a huge role in terms of the genesis of asthma in early life, and allergic sensitization continues to impact asthma in later life, and that's obviously tightly coupled with type 2 inflammatory mechanisms. But as patients age or even adult onset asthma, we see other mechanisms that we think are involved in asthma, including non-type 2 mechanisms, and how these two arms of the immune system, so to speak, may interplay in shaping asthma phenotypes later on. The potential role of microbiota, I think, are real opportunities. As we get older and as patients have disease that doesn't go away or persist or gets more severe, we have to also think about the impact of potential treatments, including inhaled and oral medications. And I'll show you some examples of where studies have looked at that in terms of host microbiota interactions. In COPD, a very similar type of diagram, but in terms of the exposures, we do know that, of course, smoking exposure or biomass pollutant exposures are inciting factors that alter innate immunity, decrease mucociliary clearance, and that non-type 2 mechanisms in general are thought to be much more prominently involved in the inflammatory processes in the airways that lead to COPD. There's also increasing recognition that a subset of COPD patients may have more type 2 inflammation and potentially be more responsive to inhaled steroids, and that's an emerging area of clinical investigation about how to potentially leveraged information about the host and possibly microbiota interactions to inform treatment decisions. I think an interesting sector that has yet to be looked at as closely is the potential role of host microbiota interactions in pre-COPD, and what are the processes and pathways especially involved that shape susceptibility of smoker to develop COPD in one individual and another individual to not develop COPD at all. That's really not well understood. So as far as evidence and approaches, I sort of have been thinking about how to frame this talk, which in some ways is a bit of a challenge because of the chronicity of these diseases and the complexity of all the factors that need to be considered. I thought I'd break it down into clinical considerations, computational and statistical considerations, as well as the opportunities for bringing in more traditional, so to speak, wet benchwork and in particular culture-based methods. So I was going to highlight some examples of studies, sort of give you an idea of approaches in each of these realms that are highlighted in yellow here. And Lindsay has already alluded to some of this in the realm of CF, where there's been a lot of work of this preceding us thinking about adult asthma and COPD. So as I alluded to earlier, asthma is really a disease across the lifespan. And in the host microbiome literature, there's been a lot of data and evidence that's come out over the last several decades from many cohorts that some of you are probably familiar with, but really have leveraged the opportunity for longitudinal analyses. And I think that's a critical aspect that's lacking in how we think about chronic pulmonary diseases in adulthood, is the opportunity to try to follow patients long-term. And there are several cohorts that are attempting to try to do that in older patients. So just to show you one example, so this is example one of a study where I thought they elegantly leverage a longitudinal birth cohort design, but also leverage frequent sampling, as well as bring in some of the omic techniques in terms of looking at host responses. So this is a study that comes from the COPSEC cohort, which is a very large birth cohort study in Copenhagen, Denmark. And they've published numerous studies over the years looking at the upper as well as the airway microbiota, as well as the gut microbiome. And in this particular study, as you can see from the title, what they present data on is the potential role of epigenetics as a mediating factor in linking dysbiosis in the upper airways in early life to allergic rhinitis at the age of 6, or allergic rhinitis as a precursor potentially, or a comorbidity of asthma and the allergic phenotype. And so what they did here is summarized very quickly in this table. They collected hypopharyngeal samples at age 1 week, 1 month, and 3 months. They performed DNA methylation analysis from nasal samples at age 6, as well as concomitant gene expression studies from nasal epithelial cells at age 6, and used some, I thought, really elegant approaches to try to integrate this data and ask the question, one primary question, as to what is the relationship between the microbiota in early life measured at those time points, as well as the epigenetic pattern later in life, and the association with that clinical outcome, which is allergic rhinitis. This figure 4 here is essentially the summary figure of what they propose as a framework for thinking about this, but essentially encapsulates the results that are detailed in this particular study. And what they found in a nutshell is that the decreased diversity or decreased richness of upper airway samples from the hypopharynx at age 1 week, but not so much 1 month or 3 months, was associated with an altered DNA methylation pattern at age 6, and a particular module, that DNA methylation pattern, was correlated with these specific genes that are involved in lysosomal activation and bacterial invasion of epithelial cells. And they did attempt in a mediation analysis to show that the epigenetics pattern may be mediating this link to allergic rhinitis in early childhood. What about in adulthood? As I don't have a bar underneath here to show you longitudinal studies, because there's actually very few in the study of chronic asthma and COPD, and that poses challenges when we're trying to leverage cross-sectional data for the most part and glean what we can from it. This is just a summary figure to demonstrate the thinking about how the microbiome may serve as an interface between susceptibility risk factors that are known for asthma, as well as the known immunology of asthma, and the different phenotypes that we see in the adult clinic that are very simply broken out, that top layer of this map. And on to the left here is sort of just the considerations of exposures, comorbidities, and treatments should really be here as well, that we have to think about that can potentially confound, or at least be a factor that needs to be adjusted for in thinking about host microbiota interactions in chronic asthma or COPD. Very briefly, associations that have been reported over the last 10 years or so between alterations in the airway microbiota or gut microbiota and clinical markers and features of asthma are listed here, including airway hyperreactivity, the severity of asthma, symptom control, and in particular also immune response patterns, as well as treatment response. And some of the a smattering of references are shown there. I'll just walk you through two of these studies, which I just happen to know intimately. And this is an example I hope to highlight how we can meld longitudinal study designs with an interventional design and make the best use we can of studies that we can get from patients. Every sample is precious, and the data we can generate, we should try to make the most of it. So this was a multi-center study we conducted in the NHLBI asthma a couple of years ago now, and we set out to ask the question of whether there's two primary questions really. What are the differences in the microbiota of the lower airways that are associated with asthma versus atopic state, because atopy is very prominent and is a potential confounder of those associations in earlier studies. And also, what is the effect of inhaled corticosteroid treatment, which we, in this study, subjected the asthmatic group only to, and did a 2-to-1 randomization versus randomization scheme of delivering fluticasone versus placebo-controlled inhaler for 6 weeks. We performed bronchoscopy and sputum reduction before and after the intervention within the asthmatic group, which allowed us to ask some questions regarding the potential effect of steroids directly. All these individuals, the asthmatics at baseline, were steroid naive and had very, very mild asthma with minimal exacerbation history. So in a nutshell, what we found, and that was reported in those two publications I showed earlier, is that we saw some organisms that were relatively enriched or relatively depleted, that were asthma associated, and we think strongly asthma associated because they were enriched in the asthmatic versus atopic group comparison, as well as the asthmatic versus healthy non-atopic group comparison. And we quantified bacterial burden using 16S-RNA gene copy number as a proxy for that, and showed in the sputum that this difference in bacterial burden between T2 high, or those who had a type 2 high inflammatory state versus type 2 low inflammatory state, bacterial burden was higher in the T2 low state. And this mirrored what we saw in similar analyses using bronchial airway samples in an earlier study. We then took BAL, or bronchoalveolar lavage fluid samples, and did some cytokine analysis with that. Did a cluster analysis on the BAL cytokines, and then asked whether the two clusters of immune phenotype as represented by this cytokine clustering differed in microbial or bacterial characteristics here. And although the group was small, we saw that there was a subset of individuals amongst the T2 low group, so again, the group that had higher bacterial burden to begin with. There was a subset that had a more pro-inflammatory signature in the BAL, and that was associated with decreased diversity in their corresponding bacterial compositional profiles. When we looked at the response post fluticasone treatment, we saw shifts in the composition of the microbiota before and after in both the bronchial airway samples as well as the sputum samples. But interestingly, when we classified the subjects as whether they responded to inhaled steroids or not, defined by whether they had an improvement in their airway hyperreactivity by methacholine challenge, we saw a greater change in the sputum microbiome characteristics in those who did not respond by that outcome parameter, suggesting the possibility of off-target effects, corticosteroids. And then applying an approach that's an in silico analysis that can predict the possible bacterial functions based on the 16S-RNA gene sequences, we identified a couple of pathways that were predicted to be relatively enriched in those who did not respond to steroids, and these were involved in metabolism of xenobiotics as well as exogenous compounds. What about in COPD? So this figure on the left here is from a relatively recent review, just basically highlighting the heterogeneity of COPD and the relatively poor knowledge we have down here about host microbiota interactions and how they may play a role in the COPD pathogenesis or the phenotypes of COPD. In this table is just a brief summary of associations that reported mostly from cross-sectional analyses of how altered microbiota features from sampling of the upper areas is associated with the presence of COPD or the diagnosis of COPD, also the severity of COPD, and outcome measures including symptom scores, lung function parameters, as well as airway immune response patterns such as neutrophilic versus eosinophilic inflammation, and a number of studies in cohorts that have looked at more frequent exacerbator, that include more frequent exacerbator subjects have delineated associate differences in the microbiota immune relationships with different exacerbation phenotypes. So this is one study that looked at that, although they didn't look so much specifically at exacerbations in this study as they had in previous analyses from some of these cohorts. But I thought this was an interesting example of an attempt at a meta-analysis, so to speak, of microbiota studies. And I think it's a Herculean effort here, and some of the challenges are evident, but also the the possibility of what you can do when you're able to meld data in an intelligent fashion are illustrated in this study, which is in Press in the Blue Journal. So this is a study that utilized these 3 cohorts of COPD patients from the UK, the COPD MAP, ARIS, and Beat COPD cohorts, all of which had a subset that were fairly frequent exacerbators and generally consisted of individuals with more moderate to severe COPD. So keep that in mind. Well, what these investigators did was to take the information about the inflammatory profile of their sputum. So here, classifying the sputum inflammatory pattern as neutrophilic predominant, eosinophilic predominant, mixed, or paucigranulocytic in pattern. And then looking at microbial parameters of the bacterial community composition by these metrics, such as Shannon diversity, which is a reflection of alpha diversity or the diversity within a single sample. And you can see here, those who had neutrophilic and predominant inflammation had a decreased diversity or alpha diversity compared to the other sputum inflammatory phenotypes. What I think was interesting about the studies is that within the neutrophilic phenotype, when you look at the distribution of the community types, meaning the dominant bacterial species or organism that define that community, that there was actually kind of a split within the neutrophilic prominent group. And what they ascribed the label to by these authors was a homophilous predominant signature associated with neutrophilic inflammation and a more balanced, meaning that there was not a predominant pathogen signature like homophilous or others, and is actually comprised of a smattering of organisms, including oral organisms as well as streptococcus. When you take that information about the sputum inflammatory phenotype, as well as the bacterial community type, they then looked at sort of potential differences in sputum inflammatory mediators that they had measured from the sputum supernatants. And if you keep your eye on the blue and the pink here, the neutrophilic balance group that didn't have a predominant pathogen profile that was identifiable was associated with greater representation or greater levels of IL-17A, IL-6, et cetera, whereas the pink neutrophilic inflammatory group, but that had a more homophilous dominant profile, had more of these pro-inflammatory mediators that we think about in COPD quite a bit, IL-1 beta as well as TNF alpha. It's an example of melding host immune response or inflammatory response information with actual measurements of cytokines data, overlaying that with looking at the community composition to potentially derive some new hypotheses about what might drive differences in COPD phenotype. Now, I mentioned the previous study was in more moderate to severe COPD, and there's been relatively fewer studies in milder COPD or even smokers without COPD. And this is an example of a study we did within the Spiromics Network, which is a multi-center NHLBI prospective observational study. A subset of individuals in this study underwent bronchoscopy, and we had the opportunity to take a look at the bowel samples from these subjects, which were predominantly represented by individuals who had a smoking history but did not have COPD based on clinical lung function criteria, as well as individuals with mild, moderate COPD or GOLD 1-2 stage for the most part. And this principal components plus, this is meant to display a summary snapshot that, first of all, in general, we did not see a strong differentiation between patients with COPD defined, as I said here, with very mild or moderate COPD versus smokers without COPD, and that's the X's and O's in the background in this figure here. But when we overlaid sort of the what is driving this variation community composition, which is the red arrows here, these red vectors, and you can see here that Haemophilus and Pseudomonas is kind of driving the community variation this direction with these samples. Down here is Streptococcus, and to the left here is more oral organisms such as Prevotella and Veillonella. We then overlay that with these blue vectors, which are the clinical features and measures that from the Spiromics data set that we tested associations with variation community composition here. Of interest to us, we did not really anticipate this. We saw not a very strong relationship with lung function parameters, perhaps because of the very relatively mild nature of the clinical phenotype here, but really a more stronger relationship between bacterial community composition in the lungs and readouts of CAT score, which is readout of symptom burden and bronchodilator response. And these are strongly correlated with Streptococcus relative abundance in the data. Because of this interest, we thought we'd try to identify these Streptococcus, which is not very well or very easy to do with 16S RNA-G sequences. So we went back to the bowel samples we had, and we actually had a priori in designing the bronchoscopy study thought to save a sample that might allow for future culture cultivation. And so we went and isolated primary isolates of Streptococcus as well as some other species of interest and did biochemical molecular analyses as well as gene sequencing to identify specific species of interest using some traditional microbiology approaches. So an example of the potential value of overlaying traditional culture-based techniques to look at primary isolates, which may behave very differently from laboratory isolates that we might otherwise test in lab for more mechanistic experiments. And then last but not least, I thought I'd show you an example of a multi-omic study. This is also an abstract from the Spiromics cohort, so you can take a look at it, and the abstract number is up here. But taking the bowel microbiome data I showed you on the previous slide, we also have paired metabolomic data using both untargeted and targeted methods. This is a very busy slide, so I don't anticipate going through that or walking you through it, but in a brief nutshell, current attempt at sort of doing multi-omic analyses using 3 different data sets, between pairwise analysis of the bacterial microbiota data, the untargeted metabolomic data, and the targeted metabolic data. I'm using an algorithm called Diablo for feature selection and coupling it with penalized regression models to try to determine what are the features from the microbial compartments as well as the metabolite features that are co-associated with these clinical outcomes. And in a nutshell, in figure 1A, these are classification accuracies where we show that, that the incorporation of microbial and metabolite features was able to predict some of these clinical outcome measures down here on the x-axis. I know you can't see, but this was even after adjusting for a number of covariates of relevance, including age, demographics, steroid use, as well as antibiotic use. So with that, I will just show you my summary slide, and my takeaway points, at least for me, in thinking about these studies, is that dissecting the role and impact of host microbiota interactions in chronic diseases can certainly be challenging because we often don't have the opportunity for longitudinal analysis like birth cohorts or in the cystic fibrosis population where sampling is generally more ready to obtain. But I think a priori planning and study design and execution can help address many of these challenges. And as I mentioned, longitudinal and interventional aspects where they can be incorporated in a rational manner and feasible can really augment the value of some of these clinical studies. And therefore, thinking about how you plan sample collections, how you're going to process them, and how you may generate the data and couple that data together with in terms of the clinical data that's captured, and thinking about the possibility of bringing in some traditional wet bench methods can really, I think, increase the yield from otherwise costly clinical studies that we'd like to be able to not only test primary hypotheses, but also generate new hypotheses that allow for more mechanistic understanding down the road. So with that, I'll stop here. I know we're taking questions at the end, but I thank you for your attention. I'll turn it over back to Ben.
Thank you, Ben. Thank you, Yvonne. And thank you all for attending, and I appreciate the invitation to this great session. So the topic of my talk is bringing sequencing to the bedside in our management of ICU infections. So I have no disclosures. So I'm going to, with my time, try to make an argument in 4 parts. Firstly, I'll argue that pneumonia in the ICU is really more of a syndrome than it is a precisely designed disease process. 2, that our efforts at bringing precision medicine to pneumonia, which is what we want to do, will likely be futile without major technological innovation. 3, I'll make the case that metagenomics and metatranscriptomics hold the potential to revolutionize both our understanding of the biology of pneumonia, but also our diagnostic approach. And then finally, I'll make the case that in 2021, we're limited not by the availability and cost of the necessary technology, but rather our ability to make sense of the colossal amount of data that we generate. So from the top, I'm going to argue that pneumonia in the ICU especially is more of a syndrome than a precisely defined disease process. So what do I mean by this? Imagine a spectrum where on one side we've got pure syndromes, on the other side we've got the opposite, precisely defined disease processes. On one end, you might have something like CML, which I suspect you all know is at this point, a very well described, defined, understood biologic process. We know the chromosomal translocation necessary to make it happen. We know how to diagnose it molecularly. We know how to treat it molecularly. And there's no ambiguity. We all agree with a molecular diagnosis when we see it. At the other end of the spectrum, think of psychiatric disorders. So literally any purely psychiatric disorder ranging from depression to anxiety to psychotic disorders, we don't even have a pretense of a biological diagnosis. We define it based on clinical features, symptoms, constellation of findings. And there's a lot of subjectivity in making this assessment. Historically, we lived on the left side of the screen. So if you went back 100, 150 years ago, you might describe diseases that make you yellow just based on clinical features. Whereas nowadays we would make a molecular distinction between viral infections like hepatitis C and hemolytic anemia. So the history of progress in biomedical research tends to be moving from the left side of the screen to the right side of the screen. I'll ask you in the ICU, where do we live? We live on the left side. So if you think about sepsis, sepsis is quite clearly a syndrome. It's the sepsis syndrome. It's defined by clinical features. We have a general sense that we understand the biology behind it, But the fact that we redefine it every couple decades tells you that we really don't have an ironed out molecular diagnosis. And the fact that there's no gold standard, there's literally no biopsy that you can perform on a patient for the pathologist to confirm, yes, this patient has sepsis or septic shock, tells you that we're really dealing with more of a syndrome than a defined disease process. How about ARDS? Well, we can fool ourselves. We can say, well, histopathologically, that's diffuse alveolar damage. That's a well-defined disease process. But we know that in clinical practice, it's much more like psychiatry than it is like oncology. We use the Berlin criteria, which are syndrome-based definition. And we know that when you do pathology, when you do autopsy on patients who die of ARDS, often what you find is not diffuse alveolar damage, but competing diagnoses. So even the things that we think are biologic processes are actually more syndromic. So my question is, where does pneumonia fit on this spectrum? And I'm going to argue that it's tempting to think it's on the right side of the screen because, well, we know it's bacterial overgrowth in the lungs, and we can model it in animals by squirting bacteria into the lower respiratory tract and looking at the damage that causes. But in practice, it's much more of a syndrome, and I'll make the case a couple ways. For one, it's worth thinking about intra-observer variability. So you've probably heard of the kappa statistic, and it's basically saying if two competent clinicians assess the same patient and say, does this patient have this diagnosis? How commonly do they agree? How frequently are they in agreement? The agreement for pneumonia, especially in the ICU, is abysmal. So this is an important study from 20 years ago, looking at patients using a validated pulmonary infection score, using all the criteria that we use every day. So things like your chest X-ray, sputum consistency, identification of pathogens in the respiratory specimens. And the kappa was terrible, 0.16. That's way over here on the left side of the screen, telling you that day to day, we do not agree on who has pneumonia in the ICU. But you could say, well, that's a problem just of incomplete data, that you're using chest X-rays, which are really bad in the ICU. You have suboptimal specimen collection. So we did a similar study looking at patients at our center. This is with two trainees of mine, Rishi Chandaraj and Jenny Sheffield. And these were cases where we had everything you could possibly want diagnostically. So we had CT scans, we had bronchoalveolar lavage specimens, we had finalized micro results, both culture and PCR based. And even with that complete data, still infectious disease and pulmonary critical care physicians, their kappas, they only have fair to moderate agreement when it comes to who does and does not have pneumonia. So even in best case scenarios where you have all the data you're going to get with existing diagnostic tools, there's still a lot of subjectivity and disagreement about who does and does not have pneumonia. But maybe you say that's just a problem of measurement, and the pathology itself, the disease process itself, is a disease process. Well, if you actually look at autopsies of patients who die of possible pneumonia, the pathologists themselves don't necessarily agree. So you'll have variation ranging from 18% to 38% of the patients in this cohort of pathologists agreeing of whether they do or do not have pneumonia. So I would argue that despite the temptation to think of pneumonia as a well-defined disease process, really it's a syndrome. So the next argument is that in order to improve this, to bring precision medicine and tailor therapy to individual patients in front of us according to what they need, it's not likely to work much more than current practice without major technological innovation. And this is informed by history. So for one, if you look at how we got from the left side of the screen to the right side of the screen in other disease processes, it tended to be technological advances. So things like being able to understand the virology and have PCRs to quantify viral load, to understand the biology of malignancy. And I would argue that until you have that, really you're only making at most incremental advances. I would ask you, how much better is the DSM-5 and the DSM-4 in improving our diagnosis and management of psychiatric disorders? How much better is sepsis 3 than sepsis 2? These are really incremental advances compared to the profound advances we get from technology. That's also true if you restrict our thinking to pneumonia. So again, my trainee Rishi Chandaraj and I gave some thought to this and wrote an essay a couple of years ago on what we think is a looming paradigm shift in how we think about pneumonia. And we looked back at the history of advances in pneumonia diagnostics, and a couple things emerged. For one, it's always been motivated and informed by technology. So even the dawn of germ theory, so Pasteur and Koch back in the 1880s, we think of them as just sort of being inspired geniuses who saw through the biology and understood that there was a defined pathogenesis behind all these infections. But they were also beneficiaries of technology as well, namely microscopy and cultivation. Koch invented, or was the first to apply oil immersion lenses to respiratory specimens and developed anaerobic cultivation. Pasteur developed pure culture. So, anaerobic cultivation. So obviously microscopy and cultivation propelled our modern understanding of germ theory. Urinary antigens, PCR, think of where we'd be in the coronavirus crisis without PCR. But likewise, innovation has happened on the host side, but these have tended to happen in isolation. So we've had advances in our understanding of what's happening with the bugs, advances in what's happening on the host, but it's left to the clinician at the bedside to try to reconcile these and perform an informed integration. And the trend has been from cellular to molecular advances. And I think that's ultimately what's going to take to get us to go from the left side of the screen to the right. So what is that going to look like? So here's where I argue that metagenomics and metatranscriptomics hold the potential to fill this role. So first, let's talk about something that's not metagenomics, but is commonly confused with it, which is 16S RNA gene amplicon sequencing. Now, this is the workhorse assay for most microbiome studies. So a lot of what Yvonne and Lindsay were showing this past hour is based on this. This is the sort of workhorse standard approach to characterizing respiratory specimens using microbiome techniques. You extract DNA from a specimen. This is mostly host eukaryotic DNA. A small minority of that is microbial. So you enrich, you use a PCR step, you amplify the 16S gene, and then it's those amplicons that you sequence and you perform your ecologic analysis to understand who's there. And this has been very useful, but it was never really meant for clinical diagnostics. It's too slow, it's labor intensive, it takes a long time, and it doesn't tell you species level identification. It just tells you roughly genus level identity. But we have learned a couple things in ICU respiratory infections. So I'll highlight a couple studies here. The group at Penn, led by Brendan Kelly and Ron Coleman, looked at serial specimens from mechanically ventilated patients in the ICU and noticed a couple of things. For one, regardless of whether the patient ultimately developed pneumonia or not, clinically appreciable pneumonia, there is a change in community structure and a drop in community diversity. So this was independent of their ultimate adjudication. And often when you ultimately identify ventilator-associated pneumonia, there have been changes in the community structure and emergence of a dominant pathogen in the days leading up to that. So that suggests that what we call pneumonia in the ICU, clinically detected with our clinical impression, may just be a late manifestation of some microbiologic or ecologic process that's evolving, an immunologic process that's evolving in the days leading up to it. Another paper I'll highlight is one of ours. This is with a collaboration with Louis Bos from the Netherlands. And we looked at lower respiratory tract mini BAL specimens from mechanically ventilated patients, and we quantified and characterized their lung microbiota. And what we found was that even to the exclusion of any clinical assessment of pneumonia, so patients who have no clinical suspicion for pneumonia at the bedside, the lung microbiome was predictive of their outcomes. So on the top here, we have quantification of lung bacterial DNA. So how much bacterial DNA we found. You see that it stratifies nicely, and that's an independent predictor of ventilator-free days. So how quickly until you're alive and off the ventilator. And the identity of the bacteria mattered as well. So specifically gut bacteria in the lungs, and this is something we and others have seen as well. The presence of gut bacteria in the respiratory tract, even independent of any clinically appreciable pneumonia, was predictive of bad outcomes, suggesting that it's not just our imperfect assessment of pneumonia, but the biology itself is probably much more complicated, and the microbiota we're detecting there, even outside of pneumonia, probably have some immunologic and pathologic role. So that's 16S sequencing. What's metagenomics? So metagenomics is the same process, but minus the PCR step. So you still extract the DNA, but then you sequence all of that. So it's much less biased, and you get much greater taxonomic resolution. So you're getting not just genus, but species and strain level identification of the microbes. You're getting genes other than the 16S genes, so you can have a sense of antimicrobial resistance or virulence potential. That's metagenomics. If you do RNA instead, what you've got is metatranscriptomics. And this is a really exciting technology in that it doesn't just tell you who's there, it tells you who is viable, who is actually transcribing, and what specifically are they making, what are they doing. So this is where I think we are, and really what's the bleeding edge of technology in ICU pneumonia diagnostics. And it's really seducing to think that this is going to be a major step forward. So we will have microbial metagenomics, in other words, characterize all of the microbial DNA in a specimen, microbial metatranscriptomics, all the RNA that they're transcribing to distinguish the viable from the dead, and rich host readouts. So we're doing host transcriptomics to, instead of just asking, is the white blood cell count high, actually say, what genes does the host think are worth transcribing right now and expressing right now? And the best example I can point to of the power of this is a study by Chaz Langelier and Joe DeRisi and Carolyn Calfee a couple of years ago on PNAS. And they did exactly this. They did all of these high dimensional molecular measurements in respiratory patient specimens in the ICU. And they showed convincingly that it can be done, and it can do about as well as a human adjudicator of saying, does this patient have a lower respiratory tract infection or not? But this highlights a real problem for these studies, and one I don't think we have a fix for, is we really lack, we're not getting autopsies. And I told you, even autopsies are problematic gold standard. So at the moment, there's a sort of low ceiling for how well these models can perform, given that they can only perform as well if we train them on our own imperfect clinical adjudication. But it showed that it can be done. And my final argument is this, is that even now in 2021, we're limited not by the availability and cost of this technology, but rather by our ability to make sense of the data. So what Chaz and Joe and Carolyn did in that paper was using impractical techniques for day-to-day application in the ICU, right? So this is manual DNA extraction, pulling your specimen, sending it to the sequencing core, using Illumina shotgun reads to do your readout. I think this is going to change that. So some of you may be familiar with this. This is the MinION. This is a handheld sequencer, a USB-powered sequencer that provides on-demand single specimen sequencing. And it works very differently from conventional sequencing approaches. So it's a nanopore sequencer. It has a pore from an E. coli cell wall suspended in a membrane, many of these pores. It's the exact right size and orientation so that nucleic acids one at a time go through. And think of it as performing an EKG on this molecule. So it's measuring the change in current as the DNA or the RNA goes through. It turns that squiggle into base pairs, so A's and G's and C's and T's. And then you can classify that and identify bacteria or fungi or any potential pathogens that's in there. And to give you an idea, this is the team from the lab that's working on this. A few years ago, patient in the ICU, concerned for infection, got a bronchoscopy. Within an hour, we were extracting DNA. Within a few hours, we were starting sequencing. Within a few hours from that, we'd identified Pseudomonas aeruginosa as the dominant bug in the specimen. And sure enough, the next morning, the clinical microlab has cultured out Pseudomonas aeruginosa, confirming that that's what it found. So this is showing already 4 or 5 years ago that you could use this on-demand technology to identify pathogens using a metagenomic approach. That was a proof of principle case study. Justin O'Grady and his group at the UK have shown that it scales. So this is a study where they did 40 derivation, 40 validation patients with suspected respiratory infection, used a similar approach, and showed that this can be done in under 6 hours. And it showed fantastic sensitivity. So if you have a culture identified pathogen that we all agree is the cause of pneumonia, this technique is very, very good at finding it. The specificity was lower, but I would argue the specificity is really incalculable, because the truth is we really don't know the biological and clinical significance of all of the signal we find on that long tail of taxa in a respiratory specimen. So this is where I think that we can't just plug it into our old model of it's either a pathogen or it's a colonizer or it's a contaminant. But it does show in a really exciting way that it is feasible. This is actually not cost prohibitive. So the sequencer itself is about $1,000, and you can determine the cost based on what microbial depth, sequencing depth you want, but it's less than we get charged for a respiratory panel. So an RPAN, a PCR multiplex panel. And it generates a tremendous amount of data. So within, you could run DNA and RNA at the same time. It is metagenomics and metatranscriptomics on two parallel sequencers. You can be generating more than a gigabase of data an hour. And just to be provocative, I would argue that a single specimen from a single patient can generate more data in a few hours than an entire RCT for pneumonia diagnostics 15 years ago. So at this point, we can generate data far, far faster than we can make sense of it. And that's where I think we are. Or where we will be soon, is we now have the means of generating on-demand DNA and RNA sequencing, characterizing microbial metagenomics and metatranscriptomics, as well as rich host metatranscriptomics as well. We can perform quantification, which still matters. A lot of what we're doing is just saying who's there, but quantification, how much is there, is surely important. So rapid quantification of that. Likewise, I think rapid quantification, bedside quantification on the host side. I'm not the only one to point out that it's kind of crazy that in the COVID era, we were giving potent biologics, anti-IL-6 agents to patients without an ability to measure their IL-6 at the bedside. And in many cases, we would get that send out lab back in a few days and find out that it was normal or low. So until we can precisely quantify what we're trying to modulate on the host, I think it's probably going to be futile. And then finally, exhaled breath is actually a rich biospecimen that's been looked at for a long time, but integrating the actual metabolomic signature of infection versus some other state is going to be profitable as well. And you'll notice that where I think we've gone is from thinking on the cellular and molecular level to really thinking about systems, networks, and communities. And I think the path forward is not thinking of the bug and the host as silos, but rather an integrated network that needs to be interrogated together. And with that, I am done, and I thank you for your time, and I'm happy to entertain questions with Yvonne and Lindsay.
Great, thank you. That was a very provocative talk, and thanks to all the speakers. It's a really fascinating talk so far. So we're going to open up to some questions from the audience. When we know all the bugs are present in a respiratory sample, do you have thoughts on how to, to differentiate better in terms of infection versus colonization? Is that, go to more what you're talking about, quantifying and looking at the metabolic signature?
Yeah, I think it's a much harder question to answer than it used to be. I think we used to make distinction based on CFU counts and BALs, but you're right. It's basically impossible to use these incredibly sensitive sequencing techniques on respiratory specimens and not find microbial signal. And I would go broader than just colonization, because I think we can find microbiota in even healthy lungs, even if they're not strictly speaking colonizing, right? They might be quite transient. They might be aspirated, perform some kind of immunologic effect, and then expectorated or cleared. And that doesn't mean they don't, just because they're transient, doesn't mean they don't have immunologic and clinical significance. I mean, that's actually in the lung microbiome field, one of the most consistent signals we found is that lung bacterial burden is predictive of outcomes. So a few papers now in idiopathic pulmonary fibrosis. We had one recently in lung transplant, and I showed data on that in mechanically ventilated patients. But these are importantly not just patients with pneumonia. So I don't know if we call that colonization. These are patients where you would not find the same bug by culture on repeat sampling, which is classically what I mean by colonization. And yet these non-pathogenic or non-infectious microbiota seem to be clinically important. I think that's a profound biologic, ecologic, and clinical question that we don't have a straightforward answer for right now.
Yeah, and I'll pose that same sort of question to Lindsay as well. I mean, I think in the CF lung, we dealt with this for a long time. What's a colonizer? What's a true pathogen? Something that really wasn't touched on today was the role of fungi and all of this. And we see in fungi and all of these diseases we talked about today. So Lindsay, do you want to give thoughts, and then I'll ask Yvonne as well?
Sure. Yeah, it's a good question. I mean, thinking in particular about fungi, I'm sure you can think of many patients with Aspergillus who have repeated cultures with Aspergillus for a long time and don't seem to have any clinical effects from it. But whereas other patients will have APPA or really seem to have a decline. So I think it's not as clear as if it's a colonizer or a pathogen. And I think I probably, as Bob mentioned, incorporating the rest of the bacterial community and the host response, and these things probably all work together to determine when something acts like a colonizer or a pathogen. So there's not going to be a clear, you can bin something into, is this good or bad? Is this a colonizer or a pathogen? It's really going to depend on all of these factors together.
Yvonne, do you have thoughts on this topic?
Yes, I do. I was reminded with that question that about 15, 20 years ago, there's a researcher named Arturo Casadeval who's proposed moving away from those kinds of terminologies because of the new data information coming out about what exactly it means. And I think Bob and Lindsay are right on. I think we have to think more about sort of the not so innocuous presence of these organisms and looking at in relation to the host immune responses, because they certainly could be contributing to pathogenesis or persistence of disease in ways that we don't necessarily think of as a traditional acute inflammatory response to infection.
Great. Yeah, I think it's certainly a challenging area that we're going to have to keep working on moving forward. Next question from the audience was dealing with the role of the gut bacteria, the gut microbiome, and how it impacts the lung. And maybe for our pulmonary critical care physicians on here, is there, could this be secondary to gut ischemia during acute illness? Maybe I'll let you tackle that one first, Bob.
Yeah, absolutely. This is a very old idea. So for more than a century, we've speculated that you've got this 3 pounds of bacteria in your lower gut. And when you get sick, your gut wall gets porous. That's not debated. And we thought, well, maybe that's how multi-organ failure happens. So whatever it is that causes transient gut permeability, you're showering the rest of your body with gut bacteria, and that's mediating organ failure, inflammation, maybe pneumonia, ventilator-associated pneumonia. In the 90s, that kind of fell out of fashion because they had trouble finding the translocators. So there were elegant studies where they were sampling portal venous blood and essentially just couldn't find evidence of transient bacteremia. that predicted subsequent end organ injury or anything like that. But as you know, given the session we're in, we know that just culture-based identification of microbes is relatively limited, and it's specifically not very good at most gut bacteria, and most namely, which are anaerobic and require special media, special culture conditions. So we've looked quite a bit at this, and indeed, if we look in the lungs of critically ill patients, we find gut bacteria. I showed you some data that in now multiple cohorts, we found that the presence of gut-associated Enterobacteriaceae, it's specifically predictive of the presence of ARDS and more ventilator-free days. In animal models, we can give them shock of any sort, but multiple models of sepsis, we can find gut bacteria in the respiratory tract. So it's absolutely plausible, and I think actually intuitive, that gut bacteria making their way into the alveolar space is pro-inflammatory and pro-injury. That's probably not the only way the gut bacteria matters in critical illness. The gut microbiome is just a source of potential pathogens, right? So it can become dominated by potential pathogens and then via the normal fecal oral route. It could be a metabolic organ that has a function and a dysfunction. It can calibrate systemic immunity. So there's probably all kinds of ways directly and indirectly that the gut microbiome can contribute to extra abdominal infections, but also organ dysfunction in the ICU, and translocation is certainly one of them.
Great. In relation to that, Lindsay, there was a question from the audience about how CFTR modulators might specifically affect gut microbiota, based on what we know about how CFTR controls this. And this may relate into COPD, so we can come back to Yvonne on this as well. So is there a role for altered immune responses, enhanced clearance of infection using CFTR modulators?
Sure. There have been some studies on CFTR modulators and the effect on CF gut microbiota, and they have shown an effect. So some of this data has come from the Hoffman lab at University of Washington, and there are changes that are observable with CFTR modulators on the gut microbiota. My impression of this is that the impact is greater on people who are pancreatic sufficient versus people who are pancreatic insufficient, and I think this is sort of parallel to the impact of CFTR modulators on infection potentially being greater in people with earlier stage lung disease who have less established bronchiectasis, so that maybe there's more room for community movement in people who have a more residual pancreatic function. But this is a big area that we're going to learn a lot more about in the upcoming years. The recent PROMISE study looking at people before and after starting Trikafta, sampling microbiota at many different body sites, but including gut microbiota. Those results will be coming out, and this will be looked at in the pediatric population as well with the PROMISE Acute study that's coming up. So I think short answer is yes, but there's a lot more we need to learn about the impact of CFTR modulators on gut microbiota, and then how does that relate to lung microbiota and clinical outcomes, I think are all still interesting areas that are really unknowns.
Yeah, Yvonne, what do you since we do know that in COPD, specifically where you can have CFTR dysfunction from exposure to cigarettes, and there's been shown some promise for CFTR modulation in that disease. Do you think using therapeutics from other chronic diseases and other areas where the microbiome has a similar picture is something that we could bring into the COPD and asthma world and things?
Are you referring to the role of therapeutics to interrogate these interactions?
Yeah, based on the data, if you find similarities in disruptions in the microbiome, can you use therapeutics from other diseases for that?
Yeah, I think the nature of the ecology is going to differ by disease. I think in CF it's clearly different, and I always think of CF as being out there as a model, but also as sort of the extreme of what can happen. I think, in my view, COPD gets closer to that in terms of with increasing severity, where you see the frequent exacerbator phenotype, and also in more severe asthma. As far as I think there's opportunities to look at the role of or taking the opportunity of therapeutics to interrogate how things change, not just in the bacterial compartment, but also the immune responses and how those interactions shape clinical outcomes down the road. I think the challenge is designing the studies and then being able to get the patients in. That's always a challenge in our adult outpatient chronic disease studies. It's really hard to get them in at exacerbation before anything else has happened. And so it requires a little bit more effort on both the volunteers as well as the study team to do that. But certainly there is opportunity there, I think, to leverage that for more mechanistic understanding as well as potentially inform precision medicine down the road.
Yeah, and hopefully we'll get to touch on some sampling at the end here. I think it's certainly important in this COVID era, and even with things like in CF, we've seen with CFTR modulators changing the amount of sputum and things that are available. Getting back to some more questions from the audience, as we shift from or thinking about the gut microbiome, Lindsay, one of the questions was about, do you think it's more likely that the anaerobes are driving shifts in pathogen expression, or that they themselves are directly contributing in the context of exacerbation? So what is that direct role of the anaerobes?
Yeah, I think both are probable, and I think probably at different times. Different mechanisms are predominating. There's some data out of the Canadian group on increases in relative abundance of strep milleri being associated with exacerbation that then improved greatly when treatment directed at strep milleri was given. But that signal also has not been consistent across the whole population. So I think we're getting more towards a patient-specific understanding of the bacterial communities and the shifts that are relevant within each patient, because I think anaerobes have been shown to be directly inflammatory and potentially pathogenic themselves. But we also discussed how they could be working in concert with the CF pathogens to be increasing their pathogenicity. So I think there's no one answer, but I think that looking at more longitudinal studies of within patient changes and understanding how these different mechanisms can predominate at different times with different patients.
Any thoughts from Bob or Yvonne on continued role of some of these less cultured pathogens and the role of anaerobes in your disease processes, and how we kind of formulate that and combine that with all the data that's out there?
I'll just add that we see similar sort of hints in chronic airway diseases, like in particular COPD. I mean, a lot of these oral, if not exactly strict anaerobes or facultative anaerobes come up interestingly in our lower airway samples. So I do believe they're down there. And the question of whether they're transient or not is going to be challenging to dissect. But I think if you can find them consistently over periods of time and across cohorts, it hints that they have the capacity to do something down there, and they probably play a larger role than we think.
Yeah, I would add only that in the other end of the spectrum, so if we think of pneumonia as an extreme case of the bugs have taken over and are wreaking havoc, on the other end, healthy volunteer humans or healthy animals, we find anaerobes, or at least DNA corresponding to anaerobes in the lower respiratory tract. And in both humans and animals, in multiple studies now, we find a strong correlation between who's there and then the immune tone of the lower respiratory tract. So to echo what Yvonne said, even if they are transient, it doesn't mean they aren't having an immunologic consequence. And there's an elegant paper out of Leo Segal's group last year showing that you can actually, by challenging mice with oropharyngeal microbiota, convey subsequent protection from pneumococcal challenge. So it suggests that the lungs have a sort of immunologic memory from recent microbial exposures. So just to add another dimension onto it, time matters as well.
Yeah, there's so many things to consider. So I'll pose this to all three of you. We've talked about a lot of great data from BL studies and longitudinal sputum, but I think certainly the era of COVID has put the challenge to us of how to get samples safely. We're seeing a lot less bronchoscopy in the pediatric setting for certain, and then we have, like I mentioned, disease treatments that reduce sputum production or things like that. So are there less invasive sampling measures that we could be thinking about moving forward, or things that we should be considering?
There's two in the ICU that I'm excited about that I'll share. And this speaks to, I saw one of the questions in the chat was antibiotic development, and something that I think these are related, and that what I said about how hard it was to give host modulating therapies without being able to readily characterize the host is also applicable for bacteria. If you got a hot new antibiotic, but it takes 24 hours to identify a pathogen by culture and 72 hours to identify susceptibilities, then you're gonna have to study a lot more patients, enroll a lot more patients than ultimately would likely benefit from the drug that you're administering. So rapid diagnostics and informed diagnostics are going to, I think, rapidly accelerate the way to deliver precision medicine and antimicrobial drug development and delivery. To do that, I think, like you said, Ben, we need better light touch sampling strategies. And two that I'm excited about, one would be in the ICU. This is obviously not applicable, but the Vanderbilt group has been looking at heat and moisture exchange filters. So in the exhalation circuit of the ventilator, there's a filter that they will put in, take out after 4 hours, and they published in Chest a few years ago, you can detect bacterial DNA in there. and it corresponds with culture-identified pathogens. So one thing we're looking at with them is in a sort of subpneumonia, so unambiguous, a more ambiguous case, can we meaningfully detect bacterial DNA? And as I mentioned at the end of my talk, we have the means of potentially extracting DNA quite quickly and characterizing it. So what if it was fast and cheap and informative enough that every morning at 6 a.m. you take that filter out, you extract the DNA, you put it in the nanopore sequencer, and by the time you're on rounds, you have this community readout of which bacteria are in the lower respiratory tract. And you could start and stop antibiotics, not just based on what the sputum from 3 days ago is saying, but actually what was present earlier this morning. I think that would be potentially transformative. Also, the use of metagenomics and actually being able to characterize antibiotic potential would also be obviously informative along those lines too. I also mentioned exhaled breath, and the vision here would be that exhaled breath is actually a rich biospecimen that has hundreds of volatile organic compounds made by the host and the bug. So in principle, it's easier to say than to actually execute, but we should be able to identify both the host immune response, but also the metabolic activity of bacteria in the lower respiratory tract. And imagine starting and stopping antibiotics, not just based on the suspected presence of bugs, but the activity of bugs. And we don't treat for 7 days, 14 days. We treat until we can no longer detect reproducing biofilm forming Pseudomonas. That I think would be a really dramatic change in the way we approach antimicrobial use in the ICU.
Yeah, I think there's certainly a lot of potential for that. Yvonne, do you have thoughts? Any other thoughts on that? It's a difficult question.
Yeah. It is a challenging question. I think for chronic airway disease, where the primary pathology is in the lower airways or small airways, to address mechanistic questions, I don't think there's going to be an easy way around trying to get sampling down there. And of course, in our studies, we do induce sputum and don't really rely on expectorated sputum like they do in cystic fibrosis studies. I think the exhaled air approach that Bob alluded to is really fascinating. It's even that or exhaled breath condensate are not great for looking at the organisms themselves. It's there's just so much noise and signal. So asking specific questions about the microbes and who's down there, I don't think will be very feasible there, but it's about the composite signature and what they're doing. And certainly in the asthma as well as COPD space, these eNose technologies where they look at patterns of exhaled VOCs has been shown to sort of be associated or potentially predict patterns of lower airway inflammation as well as exacerbation.
Yeah. Well, I think we're about out of time, so I really want to thank all our speakers. I mean, this was a really fascinating session. It was great work, really interesting questions posed for the future, and I thank the audience for paying attention and really putting also some great questions out to our speakers. So this session is recorded, so if anybody missed it, please tell your colleagues. And again, please pay attention to the rest of the programming from the Science and Innovation Center and reach out to our speakers. They're all on Twitter, so thanks again to everybody.
Thanks for attending.
Thanks,
Bye.
Ben. Thanks, everybody.
Thank you.
Thank you.